So I just want to acknowledge a few people or a few agencies before we start. Just acknowledge that the Institute for Work and Health, we operate with the support of the Province of Ontario, although these views that I'm expressing today are mine and that of my co-authors. And I also want to thank Stephanie Anthea and Cynthia Chen, who have led the analyses which I'll be presenting today, which are focusing on workplace violence. So I'd like to start by just talking briefly about a background of sort of what's happening around workplace violence here in the province of Ontario, so some recent activity. So if we go back to 2010, there was Bill 168 was introduced, which had a requirement that employers should have policies and programs in place to deal with workplace violence, workplace harassment and domestic violence that might occur in the workplace. And this required employers to have some sort of procedures in place for workers to report incidents, to investigate incidents of workplace violence, harassments or threats, or to give workers information about these policies and programs. So there was a specific change to the Occupational Health and Safety Act in 2010, which gave more of a focus on workplace violence and its impacts. From then, we've seen that workplace violence and workplace harassment have had more prominence. This is the Ministry of Labor website. So more prominence on the websites of the Ministry of Labor. We have agencies such as PSHSA, which are introducing or developing tools for workplace violence assessments, which could be conducted in any type of sector. And a couple of years ago, we had quite a unique cross-ministerial partnership between the Ministry of Health and Long-Term Care and the Ministry of Labor, which got together and focused on the prevention of workplace violence in the healthcare sector. And that involved a leadership table, which was comprised of different stakeholders within the healthcare sector and also a number of different working groups developing on both the knowledge dissemination, the assessment and how we might develop indicators to evaluate workplace violence activities, prevention activities in the province. So one of the main things, or one of the key things which has come out of this leadership table and the working group is currently Health Quality Ontario is introducing this year for the first time a new mandatory indicator as part of hospitals' quality improvement programs, which will be that each hospital will have to report the number of workplace violence incidents that occur in their hospital, and also an assessment of the number of staff they have in their hospital, and this will be used as part of assessing the quality and performance of hospitals in the healthcare sector. And this is, as I said, one of the outcomes of the leadership table on workplace violence. So you can see that in terms of understanding workplace violence, in terms of developing activities to prevent workplace violence, there's been a lot of activity, and it's not just in Ontario, it's been, bless you, it's been all around a number of different provinces and a number of different countries, but certainly workplace violence is receiving a lot more interest and research activity and other types of prevention activities than it used to. So what is workplace violence? So we talk about it, we've got activities around it, but what actually is workplace violence? So it's defined in the Ontario Occupational Health and Safety Act as three different types of activities can lead to workplace violence. So one is the exercise of physical force against a person that causes or could cause injury to the worker. But workplace violence, according to the Occupational Health and Safety Act, also includes attempts to exercise physical force, and also statements or behaviour that it might be reasonable for a worker to interpret as a threat to exercise physical force. And this is where it becomes very grey about how we measure workplace violence, because if I tell you, you know, if you sneeze one more time, I'm going to kill you, you probably think I'm joking. But, you know, it's certainly, or if you cough, Monique, you probably think I'm joking, but it really is up to each individual as to how they will perceive the person's willingness to take out that. So it becomes a little bit grey in terms of how we attempt to measure workplace violence, and this is something which I would like to discuss, or discuss a little bit more at the end. But I want you to focus on this definition, because this would be the ideal definition, and then see how well we're capturing that definition as we move through. And I'd hesitate to say we don't capture it as completely as we should currently. So this is publicly available information from the Workplace Safety and Insurance Board. This is just the number of assaults, so lost time claims that as a result of an assault, which is on the left hand side here, which is the red line, and the number of lost time claims accepted in Ontario which are not due to an assault. And so you can see over the period here from 2002 to 2016, we've seen a 42% relative decrease in the number of lost time claims which are accepted by the board which are not due to assaults. Over the same time period, we've seen almost a 60% increase in the number of lost time claims which are due to assaults. Of course, there are different scales, but in terms of the proportion of lost time claims which are due to assault, it's increased from 1.8% in 2002 to almost 5% in 2016. So we've seen an increase at the very top of the pyramid about these are assaults that have led to someone both getting injured and having to take time off work as a result. So for today, what I'm going to show you or going to present is 2 research studies and then a third little bit of a reflection on the current capacity. And so in terms of the research studies, the first one is about an examination of male-female differences in self-reported workplace violence, which is taken from the Statistics Canada's General Social Surveys. The second is looking at male-female differences in the time trends on the incidence of injuries attributed to workplace violence in Ontario using 2 different population-level data sources. And then the last thing I'll talk about is some reflections on our current capacity to monitor workplace violence as a plug for a future plenary which will be given in May, at the end of May this year. And so you'll see in terms of the 2 empirical pieces of information that there's a strong focus on male-female differences. And I want to now just provide a little bit of information about why it would be important to focus on male-female differences when it comes to trying to understand a relationship between workplace violence, or really any relationship between work and health that we might choose to examine. So the first is to describe to you that men and women have always occupied and still occupy, regardless of what our Prime Minister might tell us, still occupy very, very different positions in the labour market. Looking at the 10 most sex or gender segregated industries in Canada in 1987, and then again in 2015, you can see here in terms of these 10 most segregated industries, only one of them has changed. So public administration, which was one of the most segregated industries in 1987, is no longer one of the most segregated industries. There's actually now a 50-50 balance between men and women. But educational services, the gender segregation in that industry has actually increased over time from about 58% in 1987 to somewhere around 67% now in 2015. It gets worse when we look at occupations. So if we think about the most gender segregated occupations, so we could classify occupations into 25 different groups. These are the 12 most sex gender segregated, and on the side you can see in which way they're segregated, so whether it's male dominant or female dominant. And you can see again that the 12 most sex segregated occupations have actually not changed in Canada over this, what are we talking, 15, 25, 28, 20, 30 year, 13 plus 15 is 28 year period. Can still do maths like my daughter, who's 8. Over this 28-year period. And in fact, some of these occupations, such as childcare and home support workers, which is here, have actually increased in their level of segregation, increasing from here around about 87% to over 90% of childcare and home support workers are now female compared to 1987. To put this in context, during these time periods, we've added 1.8 million women and 1.8 million men and 2.7 million women into the labour market, into the same occupations, doing the same work. So, as I said, in terms of thinking about how work impacts health, if you don't take a focus on the different roles that men and women play in the labour market, you're ignoring a hugely important factor, in my opinion. In terms of thinking about how they occupy different positions in the labour market outside of their occupation and industry. So this black line here represents the ratio of men to women in the employed labour force, and it's about a 1-to-1 ratio at the moment. So there's 1 man for every woman in the employed labour force. If we were to focus just on people who have a bachelor's education who are in the labour force, you could see there's about 12 women to every 10 men. So women, a higher proportion of women with a bachelor's education in the labour market than there are in terms of men. Union coverage is pretty equivalent between men and women. Part-time work, so if we focus on part-time workers, there'd be 2 women for every 1 man engaged in part-time work. If we focus on holding multiple jobs, there's 15 women for every 10 men who hold a multiple job. And in contract and casual work, again, there's about 12 women to every 10 men if we focused on people in contract and casual work. So despite the fact that women have high levels of education, they're still predominantly engaged in part-time work, multiple job holding and contract and casual work. And these, again, might influence how the impact of work on health and how things like workplace violence might manifest themselves in the labour market. So, now I'd like to move to the first study. So our first study used the 2009 and the 2014 General Social Survey. These Statistics Canada, the General Social Survey program is quite a unique program in that it has different topic areas that it focuses on over time. And so in 2009 and 2014 it focused on victimisation. And so using this survey we could estimate differences in the risk of workplace violence for men and women, understand differences by the nature of violence, so whether violence was physical or sexual, the type of violence, so who committed the violence, was it someone who was a colleague, was it someone who was known to the person, was it someone else, and the sex of the perpetrator, so the person committing the violence, was it a man or was it a woman, and what's the relationship between man-on-man violence versus woman-on-woman violence, or woman-on-man or man-on-woman violence, and understand the extent to which male-female differences could be explained by workplace characteristics. So as I've just sort of overviewed, men and women occupy a different position in the labour market. As a thought experiment, it'd be interesting for us to know that if men and women had similar roles, worked in similar industries, in similar occupations, because there's not really a lot of biological reasons why that couldn't be the case, what would be the result in terms of inequalities in workplace violence? Would it be equalised, or would there still be some types of violence which, regardless of the segregation of the labour market, would remain constantly unequal between men and women? So in terms of the main outcome in this self-reported survey, I have it listed here. So it's taken from self-reported assaults, forced sexual activity or unwanted sexual touching, or from other events where an assault took place, such as a robbery. And the wording is here up on the screen. So it's an assault could be anything from being hit, slapped, grabbed, knocked down, being shot or beaten. It could also include forced sexual activity, unwanted sexual touching or grabbing. In this incident, were you assaulted in a physical or sexual way? And then they go on to ask, did this occur in your place of work? So there's a couple of things here. One is they're only capturing part of what could be considered to be workplace violence. So things such as threats are not included in this type of definition. Potentially, if there was an attempted assault, maybe it might be included, but it would probably depend on the person. And two, we're only focusing on things that occurred at the place of work. It is possible that your colleague could, or someone might, you could experience workplace violence not at your place of work, especially for people who don't have a place of work, which their place of work might be different houses if they're home care workers, or who rotate different places of work, or if something happens outside. So if something happened in a car park, where sometimes violence occurs, would someone consider that to be their place of work or not? It's a little bit ambiguous. So in terms of the subgroups that we examined, we looked at the nature of violence, so whether it was physical versus sexual. We looked at the person committing the violence, whether it was a colleague, a stranger or other. Ideally, what we wanted to do is separate the violence into the 4 types of violence which are commonly used. So type 1 would be a stranger, type 2 would be a customer or a client, type 3 would be a colleague, and type 4 would be someone who has a personal relationship, domestic violence. Unfortunately, for type, we had to combine into the other group both the type 2 and type 4 violence, and then the sex of the person committing the violence, whether they were male or female. In terms of adjustments for the workplace characteristics, we adjusted for industry in 4 broad categories and occupation in 7 broad categories. The work schedule, whether someone was working regular days or evenings or night shifts, in 6 different groups, and then also the hours of work in the previous 12 months. So as I had demonstrated in one of the earlier slides, there's 2 women for every man in part-time work, and to not take that into account, that differential exposure to workplace violence, is a limitation in a lot of the previous research which has happened to date. So the broad groupings of industry and occupation here are actually the result of a few things. One, workplace violence does tend to be focused in particular industries, and you'll see that later as I present some of the information. And also there was a change in industry and occupational coding between 2009 and 2014, which meant we had to aggregate some of these up. Some of the covariates we had, so we had age, marital status, province of residence, if the person, where they were living and their education level. In terms of the analyses, we did a logistic regression analysis. It's quite a rare event, so you could almost interpret these as relative risks if you wanted to. With sex as the primary independent variable, we adjusted our models for work hours for the exposure initially, and then we looked at the exposure plus other work characteristics, exposure, hours of exposure plus other covariates, and then a fully adjusted model which included everything. We also examined the relationship within the subgroups, which I described before, and then for those who know about the sampling of a lot of the Statistics Canada surveys, you need to do a bootstrap replicate weight procedure to adjust your standard errors. So, just to describe the rates of violence. So these are not adjusted for hours of exposure, these are just per persons, but I'll present the estimates adjusted for hours of exposure. So if we look at, first of all, on the far left side is all workplace violence. So you can see here that in terms of rates per person, per 1,000 persons of workplace violence, women have 14 per 1,000 women, and it's 8.1 per 1,000 men. The differences are quite stark across sexual violence versus physical violence. So you can see there's a very sharp sex-gender difference here between men and women, with 6.7 women per 1,000 women experienced in a sexual assault versus only 1.6 for men. For physical assault, it's relatively similar, although this is without adjustment for differences in hours of exposure to work. And then in terms of the rates, where there's a male perpetrator versus a female perpetrator, you can see two things. Is one, that there's quite a strong male-female differences when men are the perpetrator, in that women have a much higher rate compared to men, compared to when females are the perpetrator. And two, just the sheer size of the number of violent incidents where males are the perpetrator and not women. In fact, 83% of all violent incidents have men as a perpetrator. And so there's another sex-gender difference, because the reasons men are violent relates to both sex and social factors. But there's another hugely important factor when it comes to preventing workplace violence. If you had any type of piece of equipment which resulted in 82% of your injuries, you'd probably focus on that piece of equipment. The idea that men are 82% of the perpetrators, I think, often doesn't get raised in the debate. So in terms of the odds of experienced workplace violence, and in terms of what the effect of the different adjustments have, so this is our crude estimate here. So as I said, because it's quite a rare outcome, in terms of the previous slides, about 14 per 1,000 as an outcome, we could interpret this almost as a relative risk rather than an odds ratio, which is how people interpret them anyway. But so about 75% increased risk for women relative to men, in terms of just our crude association between workplace violence without adjustment for anything else. Once we adjust for the fact that women work fewer hours, you can see that risk increases to over 2. So it's a twofold increase for women relative to men after adjusting for differences in terms of the hours that people are potentially exposed to workplace violence events. When we adjust for our work exposures, which is our third column, you can see again that the risk reduces. So a lot of the patterning of workplace violence, some of it can be explained by differences in terms of men and women across occupations, industries and shift schedules. Adjustment for different covariates such as marital status, where people live, their province of residence, do virtually nothing in terms of explaining male-female differences in workplace violence. And you'd expect that because men and women don't live in very different geographical areas. They're not differentially married or not married, and their ages are fairly similar in this type of survey. And then after fully adjusting, you can see that there's still about a 60% increased risk for women relative to men in terms of workplace violence. The fact that our confidence intervals don't cross the null line, which is 1 here, when we're thinking about relative risks, or odds ratios, odds ratios, means that it's a statistically significant risk. And you'd argue that a 60% elevated odds is probably a clinically important or practically important increased risk as well, regardless of its statistical significance. In terms of breaking down, so here we have the same adjustment procedure focusing on physical violence up top and sexual violence down below. A few patterns to sort of pick out here. One is that male-female inequalities, which we had seen in terms of that first descriptive graph that I presented to you, are not as strong when it comes to physical violence as opposed to sexual violence. Adjusting, so we have an elevated risk here of about elevated odds of 1.37, crosses the line of the null line, so it's not statistically significant, but again, it could be practically important. Although, after we adjust for the occupations, industries and shift schedules that men and women work, you can see it's basically at the null. And then in our fully adjusted model, again, it's at the null. So when we think about focusing on the different occupations, industries that men and women work in, we can explain a lot about why there are male-female differences in physical violence. When it comes to sexual violence, no adjustment makes any great impact. So when it comes to sexual violence, it doesn't matter if you work in a particular occupation or industry. People feel like they have the right to sexually abuse you regardless of where you work. And Catherine Lapel has got some nice information in a study which she published in 2016 or 2017, where she looks at sexual harassment and bullying across occupational skill level, showing that it's got a very graded relationship for men. So lower skilled men are more likely to be bullied and sexually harassed than higher skilled men, but for women it's flat. In terms of male-female perpetrators, so again you can see here that when we focus on female perpetrators of workplace violence, although there's an increased risk among women relative to men after we adjust for work hours, adjusting for occupations and industries attenuates that to the null. So we could interpret it as saying if men and women worked in similar occupations, industries and shift schedules, we wouldn't see a male-female difference in female perpetrated workplace violence. But again, for male perpetrated violence, and some of this is to do with the fact that most of the sexual violence is male perpetrated, but not just because of that, you can see that the risk remains after each of the different adjustments. So you can learn a lot by focusing on male-female differences in workplace violence, both in terms of who's subjected to the violence and who perpetrates the violence. So our second study. So the second study is a bit of a change of gears into focusing on time trends and the rates of injury that are attributed to workplace violence for men and women in Ontario. So now we've moved from all of Canada, focusing just on Ontario. The advantage of this study is we're going to estimate trends in workplace violence over a 13-year period using two population-level data sources. And then using some of the claim data, we can look at differences, male-female differences in workplace violence within particular industry groups. So in terms of the two data sources that we've used for this study, we have two population-level databases. One is workers' compensation claim data, which is housed by the WSIB, the Workplace Safety and Insurance Board. So for workers' compensation data, we're focusing on injuries that have resulted in one or more days lost off work. They've been assessed or adjudicated for work-relatedness, and the Workplace Safety and Insurance Board covers about 65% of the Ontario labour market, so about 65% of the labour market could submit a claim due to workplace violence to the WSIB if they lost time off work. And the time period for the WSIB claims is 2002 to 2015. The definition of workplace violence is based on the event leading to injury, which is a standard coding which is used by all workers' compensation boards in Canada. The denominator, because we only have counts from the Workers' Compensation Board, is the labour force survey, which is adjusted for the differential coverage. Another relevant information which is recorded in the claim file includes age, sex, the occupation, industry and job tenure of the claimant. In terms of the emergency visit data, which is through the NACA's injury reporting system, here when someone presents themselves to an emergency department in Ontario, and it's a complete coverage in Ontario in terms of emergencies departments reporting this information to CIHI, the responsibility for payment is filled in by the treating healthcare provider, and they indicate that they've assessed through the interview, I guess, about figuring out how did this injury occur, how did it happen that it occurred at work or it's work-related, and so they say the responsibility for payment is to the Workplace Safety and Insurance Board. So a little bit different system in terms of attributing the work-relatedness. It's not a formal adjudication process, but in terms of collecting the history of the injury, the treating healthcare provider has determined that it occurred at work or it's work-related. Slightly shorter time period for our emergency visit data, so missing 2 years at the start and 1 year at the end. Assault in the emergency department data is based on the ICD-10 code. It's estimated just using the broad labour force survey, so anyone who works can go to the emergency department and determine it's work-related. This assessment that it would be paid for by the board doesn't take into account the differential coverage, it's just that it was work-related. Unfortunately, one of the key limitations in terms of the emergency department data is there is no other information collected on what the respondent does. So we don't know their occupation or their industry, we just know their age and their sex. In terms of the number of incidents we're talking about, in the workers' compensation data, it's just over 21,000, and in the emergency visit data, it's just over 13,000. So it's somewhere between 1,200 and 1,500 per year in each of the different data sources. In terms of trying to understand how these two data sources might be related to each other, this is a useful figure from a paper from CAM from 2012 in terms of thinking about, so the WSIB claims is sort of this box here, which is box A in this diagram, which is all lost time claims. These are not our numbers, these are the numbers from the paper which I've pulled the figure from. If you think about the emergency department data, it will include a proportion of these lost time claims. There will be an overlap, we'd expect. So there'll be some people who go to the emergency department, they've been injured, it's work-related, they end up taking a day off work, they'll report that injury to the board, they'll appear in both data sources. There will also be some people who experience an assault, don't go to the emergency department, maybe they get treated at their workplace, maybe they don't get treated at all, maybe they go to their GP the next couple of days, in a couple of days' time, but they still take time off work. So they'll appear in our claim data, but not in our emergency department data. And then we'll also have injuries that present to the emergency department, which either don't require time off work, so they'll be lost time claims that just don't get reported to the board for whatever reason. They don't feel like it, there's an alternative compensation scheme, or they determine it wasn't serious enough, but they still went to the emergency department, so they won't appear in the board data, but they will appear in our emergency department data. And we don't really know, while we know the size of the boxes E, A, B, we don't know what the overlap is, and we have really no good estimates on what box C, the work injuries that require healthcare but don't end up getting reported, or work injuries that don't require healthcare and don't get reported to the board. We don't know what the size of those boxes are. At the moment at the Institute we do have a research program that hopefully will help determine what the overlap is between boxes A, B and E. So in terms of this analysis, this is just we used a descriptive analysis of the crude rates of assaults at work by age, sex and year. We age standardised these rates using a direct method of standardisation. We estimated some confidence intervals around the weights using a gamma distribution. The regression models estimated the time trend in workplace violence, and we looked at breaks using joint point trend analysis software. And then for the WSIB claims, we looked at industry-specific estimates in education, healthcare and all other industries, only for the claims data, because that's the only place where that information was present. So these are the injury incident rates per 1,000 full-time equivalents. So we've adjusted our labour force estimates for hours of work exposure. One full-time equivalent represents approximately 2,000 hours of work in the year. Here I've got 4 lines. I don't know how well this is turning up on the webinar. The top line is what I've called the blue line, which is the rate of female claims, the rate for females in the workers' compensation claim data. So female claims is the top line, which is the blue line. The purple line, which is the second line down, is the male claims, male rate in the claims data. The green, which is the third line down, is at the start of the time series, is for men for the emergency department data. And the orange, which will be somewhere between orange and red for different people, which is the bottom line, is the female emergency department visit data. So, in terms of focusing on the trends, the time trends over time. So among women in the claims data, we saw a 60% increase in workplace violence incidents over the time period that we examined. In the emergency department data, we saw a 35% increase for women in terms of emergency department visits for workplace violence over this time period. In the workers' compensation data for men, we saw a 13% increase in workplace violence. In fact, the Joint Point software saw that there was an inflection point here at around 2007, where there was a break in the trend. So you can see here it sort of increases to 2007, then decreases after that. And in the emergency department data, we saw it was fairly flat, a 4% increase over time in terms of risk of workplace violence or incidence of workplace violence. In terms of the relative risk for men versus women, in the compensation claim data, the risk at the start of the time series was 1.3, which was significantly elevated. And among women, there was a decreased risk in the emergency department visit data, which was 0.73. By the end of the time period, those male-female inequalities had widened in the compensation claim data to 1.86. So almost a twofold increase in the workers' compensation data. And because of the increases among women and the relative stability among men in the emergency department data, the lines had reached equity. So there was no relative increase for women compared to men using the emergency department data. But certainly both data sources here, both the workers' compensation claim data and the emergency department data, tend to suggest there has been an increase in workplace violence where women are the victim of the violence, and there seems to be not the same increase observed among men. So in the workers' compensation data, we were able to further examine this and break it down by industry. So on the left-hand side here, this is the education industry. In the middle, we have the healthcare industry, and we have other industries on the far right. These are all on the same scale, so you can see, again, as I said before, workplace violence tends to be in particular industry groups, education, healthcare, and other public service industries being the predominant ones where people experience workplace violence, but not the only ones. Workplace violence does occur outside of those industries. Again, in each graph, the red line is women, and the sort of the bluish line is men. And you can see in terms of the increase among women that we had noted in the previous slide, that has predominantly, pretty much solely occurred in the education industry. So in the education, we have seen a very sharp increase in rates of violence among women, whereas we haven't seen the same rise among men. In the healthcare, we have seen sort of almost a drop among men and sort of stability among women. This is, again, I just want to remind people that we're now focusing on workers' compensation claim data that results in an absence from work for one or more days. I'm not suggesting that overall rates of workplace violence have increased or decreased in these industry groups, because I don't know, and I don't think anyone knows. But in terms of lost time claims, we've seen a decline or sort of a stability in the healthcare sector, and in other industries it's been fairly stable over this time period. So certainly the increases that we've noted in lost time claims for workplace violence have predominantly occurred in one industry group among women, not among men. In terms of one of the things we wanted to sort of check is, well, so we see this increase in the workers' compensation claims, we see an increase in the emergency department visits. Could we, is it something about claim reporting? Has something about claim reporting changed over this time period which would explain the increases? So the first comparison is, so here are the information I've already presented. So lost time claims due to workplace violence, the average annual percentage change was 2.79 among women and 2.69 using the emergency department visit data, so very consistent in terms of the increase. In terms of the work-related violence or workplace violence among men, both data sources give us a fairly flat picture as well. So the first thing we did is say, well, let's compare what's happened to claims for workplace violence versus claims not due to workplace violence. Maybe over this time period there's just been something else that's happened which has made women report more to the Workers' Compensation Board. So we'd expect to see an increase in both types of both violence-related and not violence-related claims, and we don't see that. We see that there's been a decline in lost time claims not due to workplace violence. In fact, you can look at it and sort of see these estimates, and they're actually fairly similar between men and women. So the increase that we've observed among women in relation to workplace lost time claims that are due to workplace violence has only occurred among women. It hasn't occurred for other industry groups. Clarify? Yes.
Lost time claims are claims accepted
Yes.
claims or claims like putting it in?
Accepted.
Accepted. So this is the WSIB determination that it is
Work-related.
Work-related lost time.
Yes. Yes, that's correct. And then in terms of maybe there's been an overall increase that when violence occurs, that women are more likely to go to the emergency department than they used to be. And so here we compared emergency department visits due to workplace violence, which sort of increased, and then emergency departments due to violence which was not work-related. So where the physician has determined it didn't occur at work. And again, you can see among women, the only increase is among work-related violence, not among non-work-related violence. So taken together, this would tend to suggest that the increasing rates that we're observing in both data sources are real increases, not artefacts of reporting or usage of emergency department services over time.
Peter,
yes, Cam.
Quick clarification. The fourth row under women, what you're observing there are emergency department visits due to violence by women, but the violence didn't occur at work.
The treating healthcare provider has said the responsibility for payment is not with the board. So I guess what we're guarding against here is trying to understand if there's something that's happened where when a violence occurs, women are more likely to go to the emergency department because, I don't know, stigma around it has changed or something else has changed in terms of healthcare provision, we should see increases in both these rates over time. Because it wouldn't be, oh, well, this is work-related, I'm going to go. I don't think people use that as one of the classifying criteria for attending. So, some key messages, and before I just get on to a little bit of a discussion about the surveillance. So, key messages from the study. So, the relative risk of experienced workplace violence for women compared to men. I don't think people should say, well, women are more likely to experience it or men are less likely or men are more likely, because it really does depend on adjusting for work hours properly, the type of violence you examine, because we observe for sexual violence there's quite a large difference between men and women, but for physical violence not so much. The industry under examination, it's seen in education, we've seen this massive widening of inequalities in claims due to workplace violence among women compared to men, but we haven't seen that in the other industry groups. And the time period. So the relative difference for women and men has shifted in Ontario over this time period, and had we only taken one assessment at one point in time, we'd potentially have a different rate, even though that's not due to measurements or changes, other types of changes. Some other key messages. Gendered work exposures account for male-female differences in physical violence and in female-perpetrated violence, but they don't account for female-male differences in sexual violence or male-perpetrated violence. So there's something about these types of violence, the sexual and the male-perpetrated violence, which tends to be ubiquitous across industry groups and is not patterned as heavily across different types of industries. Based on two different data sources at the population level, rates of workplace violence that result in injuries that either require emergency department care or require time off work among women are increasing. They're increasing over this time period, whereas men has been relatively stable. And based on the lost time claims, male-female inequalities in workplace violence are increasing, in particular in the education sector. So, I now want to talk a little bit about surveillance, because as I sort of suggested to you at the start, workplace violence as defined by the Act is quite broad. The available data we've got is not ideal. It's not the data that we would ideally like to have to measure all types of workplace violence. But that really should be our goal. If we're going to focus on reducing workplace violence, we can only progress as fast as our measurements can take us, talkers. So this is just comparing the different rates of workplace violence by data source per 1,000 full-time equivalents and workers for the GSS. This is around sort of the 2009-2014 time period. 4 different data sources here. So the General Social Survey is the first one, which is any type of work-related violence, which is 10.8 per 1,000 workers. In terms of physical violence from that data source, the General Social Survey at 7.2 per 1,000 workers. If we were to look at the CCHS over this time period, it does have a question on activity-limiting injuries that are acute and have occurred at work, and it does ask people, was it due to assault? That rate is about 0.4 per 1,000 full-time equivalents. Emergency department presentations are about 0.2 per 1,000 full-time equivalents, and the WSIB is about 0.41 per 1,000 full-time equivalents. So the difference between a self-report of were you subjected to violence and did it occur at work due to were you subjected to violence, did it limit your normal activities, and did you subsequently put in a claim and take time off work or need to go to the emergency department data, you can see an 18-fold difference here. Some of it might be noise, but if I had a measure that I wanted to, if I had a metric that I was interested in and I had two different data sources and they were different by 18-fold, I'd be a little bit worried. Here is looking at self-reported assaults among nurses compared to workers' compensation claims in healthcare. So this is using the 2005 National Survey of the Work and Health of Nurses, comparing that to the estimated lost time claim rate for between 2004 and 2006 in Ontario in the healthcare industry. And this is the question which was used in the nurses survey. During the past 12 months, did you experience a physical assault from a patient? So again, we're only focusing on one type of physical assault, patient-centred assault, or from someone other than a patient while working. So again, focusing more broadly on other types, so it could be a colleague, could be a spouse. So you can see here that actually the rates, the relative difference between men and women is a twofold difference here, and it's a twofold difference here. So the relative difference is consistent, which I think speaks to potentially it would make sense that the relative difference might be, because you wouldn't expect the differences between self-reporting due to putting in a compensation claim would be appreciably different for men and women. Maybe they are, but maybe not men and women in the same sector, the healthcare sector. The rates in Ontario are here, so this is only focusing on Ontario, this is focusing all on Canada. But again, we have a 200-fold difference in collecting self-reported information versus collecting using lost time claim rates to understand how we're doing. So again, if I had two measures and they were 200-fold apart, I'd be very concerned about using one of them or maybe the other to assess how we're going in terms of workplace violence, because these are a long way apart. So to end, I want to just sort of get back almost to where we started, which was around this inclusion of this new mandatory indicator of the number of workplace violence incidents that each hospital will be reporting to Health Quality Ontario as part of their quality improvement plan, starting in a couple of months. So in a couple of months, this will be publicly available information, reported to Health Quality Ontario and put on the Quality Compass website. So it's one of the questions that I have, and I think a few other people have, is just what's the likelihood, or how good will this indicator be at capturing all types of workplace violence? We don't know in Ontario, but there are a couple of studies from the US which have actually examined this particular issue just in the last couple of years. There was one by Judy Arnett's in 2015, which looked at employees in 42 different hospital units in the Midwest US. It had a fairly low-ish response rate, about 446 people. There was another one by Lisa Pompey at the University of Texas, which looked at two large hospital systems in Texas and North Carolina, a larger sample of just over 5,000 people. The Arnett study looked at all types, so all types of violence, both patient-visitor assaults and colleagues and spouses and other people you didn't know, whereas the Pompey study only looked at type 2, so patient-visitor assaults. As I said, the response rates were quite different. One of the things about the Arnett study is they actually linked the self-reports to the hospital injury reporting system. So in the Pompey study, they just asked them, did you report it? And in the Arnett study, they actually figured out, is it in there? You can see here, again, the rates of violence are fairly high, a little bit higher in the Arnett study, 62% of people versus 39% in the Pompey study, but actually quite similar to the rates that I reported from the survey of nurses previously. In terms of who reported to the hospital system, 12% in the Arnett study reported to the hospital system, 9% in the Pompey study. People don't have a problem reporting violence. You can see, well, in the Arnett study, it was just under half of people reported the violence, just over half reported the violence to someone, 75% in the Pompey study. So reported to a colleague, reported to their spouse when they got home, reported to someone. But really small numbers of people actually getting into the hospital-based system. And In these studies, the usual factors were associated with reporting, so the severity of injury. So when injuries aren't severe, it's people don't report it as much, and when they're unsure that something's going to happen as a result, they don't report it as much. But certainly it would be important to understand what this looks like in Ontario, given that we're about to use this as a quality improvement indicator for hospitals. And luckily, we've just completed a study in 6 hospitals in Ontario where we actually have this information, and there'll be a plenary on that on May 22nd. So the surveillance of workplace violence in Ontario. So again, this was a quote I was trying to say from Nunnally before. So scientific results inevitably involve functional relationships among variables, and you can't really progress any faster than the measurement of your key variables. So numbers don't understand where they come from. Numbers can come from anywhere, and if we start to use them without thinking, we can get ourselves into a lot of trouble. And I think this Dilbert cartoon sums it up pretty well. So just to conclude, so rates of workplace violence that either result in emergency department visits or lost time claims are increasing in Ontario, in particular among women, and in particular among women in education. We need to develop better systems for the surveillance of workplace violence, and we could use these systems if we did develop them to identify risk factors more efficiently, to evaluate our primary prevention efforts more accurately, and to inform information on self-reported workplace violence would certainly enhance our understanding of the time trends. So really we have very limited information. So in the GSS, we sort of cobbled that together. The CCHS doesn't really oversample enough that we could get steady, accurate estimates of the number of people who experience workplace violence. We need to have really some more focused surveys using self-reported information to better understand these time trends and the differences between men and women that we've observed in the population level compensation and emergency department visit data. And then just to plug that on May 22nd, we'll be giving another presentation which will focus on the workplace violence reporting among 6 Ontario hospitals, which is a project which we've just completed, which directly informs the QIP metric. I'll leave that up. Thank you.
Thank you very much, Peter. That was wonderful. We have some time for questions. Do we have any questions from the audience? And we have a lot of people online, so Sarah, just wave if we have any questions from anybody. Any questions?
Yeah, I found it fascinating, and I need some time to digest more of it. But I know I'm going to have a number of questions once I start to. I think it's fascinating, the information.
Okay. Well, the slides will be available on our YouTube channel in about 2 weeks' time, along with a webinar typecast. So, and you can call me or email.
Yeah, right.
I'm better on email. I don't have an accent on email. Oh, sorry. I was going to accent. Okay, Dorcas syndrome.
Thank you. I wanted, do you know yet, like you ended with saying that this is going to directly inform the quality indicator, and is that the path it's going to take, or do you know which quality indicator is on the Compass now?
So this is, so the quality indicator, this is from the Compass website, so it's only starting to be collected this year. So the quality indicator which will be reported for all hospitals will be the number of workplace violence incidents that have occurred, and next to it will be an estimate of the full-time equivalents in that hospital. And that'll be public. So I think certainly Health Quality Ontario understands the challenges with the indicator. The Ministry of Health and Long-Term Care understand the challenges with the indicator, as does the Ministry of Labour. I think everyone's on board that no one should interpret this indicator in the first year that it's operational, because there's 2 things which are happening in Ontario. One is we're trying to reduce workplace violence, but the second thing is we're trying to encourage reporting.
Right.
So based on these studies, and I won't give away the punchline for our study, but based on these studies, you could see a 50% reduction in workplace violence, but still a doubling of your incidence rate if you did a better job of reporting.
Absolutely. Yes.
So I think the challenge with the indicator is, while everyone who's developing the indicator understands the limitations in it, once it goes public, it goes public.
Right.
So what do you do if someone rings up the hospital and says, yeah, I'm disgusted, your indicator's twice as high as the hospital down the road I could go to. Now that could be because you do a better job of reporting violence in your hospital. It could be because you've got worse violence in your hospital. I mean, I think one of the challenges is, because this indicator is new, is we really need to educate everyone about how we should be interpreting it in the initial stages.
Supplementary question?
Let Cindy ask.
Absolutely.
She might have a supplementary
Might have
question.
that question.
No, I can't come back. So the education one has gone up so much, and then the healthcare one didn't seem nearly as drastic. Do you think that's attributable at all to the amount of attention that's been paid? Like healthcare violence prevention seems to have been getting considerably more than education within the system?
Yeah, I mean, I think people in education understand that workplace violence is an issue. I mean, I think the challenge with interpreting the lost time claims at this point is, I think, summed up in this slide, is that we really don't have a great understanding of how many incidents that occur, get reported to the workplace, subsequently go on to have a lost time day, and then subsequently are reported to the board so that they might be used in the statistic. So when we've got a 200-fold difference, so that's 199 incidents that are going somewhere other than the workers' compensation system. I don't know the proportion which should be going to the workers' compensation system. Now, is that appreciably different in education versus healthcare? I don't know. I mean, they're both pretty well covered industries. They both, for the most part, have short-term disability programs that people could access if they needed to. They both have strong union representation. I mean, so it really, I mean, I think so we've seen this. I don't think it's noise. I don't think it's some anomaly in the data, but it begs the question about why don't we know, and whether we need to do a better job at trying to understand what's going on in education. So I think we're getting to the point in education where through maybe the collection of this metric and by the surveys we're doing with some hospitals, we're getting to the point of better understanding what do our metrics look like in healthcare. We need to do exactly the same work in education.
So I have Dorcas, Dwayne, and me if we have time.
Yes.
Dorcas. And sorry, Peter, can you repeat the
Oh yes, of course. Excuse me. They've both been from the front. They can probably almost hear.
Do you have any sense on this slide where that new indicator will sit? And part B, in healthcare, we're doing a lot more about active surveillance. So when you go into a fracture clinic appointment, you're given a clipboard to ask questions about the source of the violence, specifically to try to get at domestic violence, but anytime. And is that part of are they doing any type of active surveillance?
Yep, so the question was so I'm on slide 30 for the people on webinar, they don't go back and forward with me, do they? If you go to slide 30, or slide 30 on the webinar shows these differences in self-reported rates and lost time claim rates. Dorcas wants to know where I think the hospital rate will sit, and is there any sort of active surveillance which is ongoing when people report. So where it will sit, based on, I mean, I could have a more educated guess, but I'm just going to give you, based on what I've told you today, it's about a tenth end up in the system. So I would imagine that it's about 4.3, which would be the rate which is in the hospital system. So 4.3 per 100, which would be in the hospital system. So about half of people who are in Ontario, a third of people experience workplace violence. It'll be 3 per 100 who end up in the hospital system, and then it'll be another sixth of that which end up going to the board, would be my guess. In terms of active surveillance, I'm not aware of anything, and I mean, I think one of the other challenges is, especially in healthcare, because violence generally tends to occur against people who provide direct care, a lot of the treatment is done themselves. They don't go to an emergency department for treatment. So, that type of active surveillance is still only going to capture a fraction, I think, of what's actually occurring.
So I wanted to ask you about the 200-fold difference that you mentioned a couple times, and the caution that I think you have to have in the trend study then, because is there an increase in lost time claims because those claims are now accepted when previously they may not have been? There are secular trends like that that go on, and then once this metric comes out, what that impact will be on the acceptance of violence claims, right?
Yep. So I think one of the reassuring things, although it's a 200-fold difference, the relative difference between men and women is identical, which doesn't reassure me, but it makes me think that the escalating difference or the escalating inequality between women compared to men is true, is real. Maybe not at the exact level, so maybe the rates are 200 times higher, but the relative difference I don't think is appreciably different, and I'm not sure how differences in reporting impact that. In terms of going back to those industry type differences, I mean, I don't know. This is one of the challenges. So has something happened in healthcare which has resulted in proportionally fewer injuries ending up in the board, which hasn't happened in education? When I think about the main culprits, which would be, you know, you'd go to short-term disability in terms of going to the WSOB, you'd go, I don't know, you wouldn't take time off because you feel like you've got to get back to your patients or your class. I don't know that those differences would explain this. Do I think we should go around and start saying that, you know, the rates are, this is the absolute rate of violence? No. It's probably a lot higher than this. But the relative difference between men and women and the differences across sectors, I don't know. I think it's better than guessing, which is what we're currently doing.
I think that's all the time we have for questions. I'll hold my question till your May 22nd.
Thank you, Monique. I appreciate that.
For coming back. Thank you very much, Peter. That was great.
Thank you.